we're surrounded by things that could potentially cause cancer, but we just do the best we can and limit and try not to lose a ton of sleep over it.
Welcome to Dog Cancer Answers, where we help you help your dog with cancer.
Dr. Kristen Lester, thank you so much for joining us today.
Absolutely. I'm so happy to be here. Thank you, Ollie.
Absolutely. We are so pleased to talk to you today because you have very specific experience that I think the lay people listening to our podcast and the veterinarians who tune into our podcast will be interested in. You are a general practice vet with a special interest in oncology who actually does chemotherapy in your general practice. So tell me a little bit about how that happened, how you got into that.
Well, so it was very organic. I graduated about 17 years ago. And, one of the things that was really impressive about going through veterinary school at that time, I specifically remember my oncology block and, going in and just talking with the specialists there and, something that's so sad, like cancer and, just it can be very, very hard and difficult. Their attitudes about it were so positive and celebratory. And, not a day went by where we didn't give a certificate or, high fives because a pet ended up achieving something, whether it was remission or their final chemo or, just did really, really well with their treatments. And so I left that block with this positivity about it and, came away with such a good experience.
Where did you go to school?
I went to Louisiana State University, which is where I'm from originally. So, it was just a good experience with that block. So then I graduated, and for the first 3 or 4 years of my career, I don't really remember doing a whole lot of oncology or chemotherapy. At that point, I was just discovering what it was like to be a new veterinarian and, learning how to spay a dog in less than an hour, or, to not panic every time I did anesthesia and just all the things that new grads go through. I remember my first allergic reaction and I was like, just learning, just being so young. But, eventually that time passed, thankfully. And about 4 years in, there was my heart dog that came into my life. I can share a little bit about Sue. She was I call her the stinky hunt dog. She really was. At that point in my career, I was practicing in a rural town in South Carolina. And so we saw a lot of hunting dogs, and she was 13. And her actual owner, I was her later in life owner. her actual owner passed away. He was an elderly man. And when I know, and when he passed, he left behind 6 animals to all of his kids. And I think they were overwhelmed and didn't know what to do. And they saw Sue was 13. So they scheduled an appointment to euthanize her. So Sue came in to my practice for that last appointment. And one of my colleagues looked at her and just thought, she still has some life. Look at this scrappy old girl. And so we asked them if he could find her a home. And so they were very appreciative and they signed her over and we took her on and I saw her in the cage and it was love at first sight. So that sneaky hunt dog got to come home and live with me. And I don't know if she, lived indoors or outside at that point. She didn't act like it, but I made her an indoor dog and we painted her toenails and I got her a tutu and she became a very fancy hunt dog.
A very fancy hunt dog.
She's a very fancy hunt dog. So I learned everything about her. She's just funny. Well, then, so getting back to my cancer journey and treating cancer, about 4 months in, she had a lump on her right rear thigh. And here's my little high horse about it. That lump was soft and it was squishy and freely movable. So what I'm trying to say is that it felt like a lipoma. And when I found it at home, I was like, oh, this is probably a lipoma. But as any good general practitioner should do, I aspirated it. And immediately I found out that it was a mast cell tumor.
The great pretender that can look like anything it wants to.
It looked just like a juicy lipoma. So luckily, my boss at the time, because I didn't want to operate on my own dog, he said, we can remove this today. And took great margins. And we had it biopsied. And it came back as a high-grade, grade 2 mast cell tumor. Yeah, I know, it's a bummer. And then at the bottom, I remember the report said these types of tumors have a mean survival time of about 4 to 5 months, which to me wasn't what I wanted to hear. I wanted more. I just got her. She's great.
Right.
She had a tutu.
Her nails were barely dry.
Her nails were barely dry. So I needed more time. And so once again, I'm very young in my career, and I just remembered this positive experience. We did have a specialty hospital about 40 minutes away. So this was Charleston, South Carolina. So I could have had that resource, but that spark was already there. And I felt like this is something that I can do. And so I started chemo with Sue. This was my first IV chemo patient. We did them blasting every week for 4 weeks, then every other week for 4 treatments. That girl had no white blood cell abnormalities. Her blood work was perfect the entire time. She had no side effects. She did amazing.
That's amazing.
Yeah. And so I felt really good about that. Well, then months later, then all of a sudden her popliteal lymph node was palpable. And then I did an abdominal.
And that's behind the knee, right?
That's right behind the knee. So her tumor was on her thigh. And so the popliteal in that same leg got big and juicy. So it was metastasizing at that point. And I did an abdominal ultrasound, and there were her sublumbar lymph nodes, which are these lymph nodes that live right at the bifurcation or the splitting of the aorta. The aorta being the major artery of the body. Yeah. And having lymph nodes there, I didn't feel gutsy to remove those. And so, at that point,
because they're so close to the aorta, removing them would be really, really dangerous. Sounds like.
It can be done for sure, and I've seen it done. I've seen surgeons do it, but it wasn't a choice I wanted to make for Sue. And so my thought process is, well, what do we do now? At that time, this was around 2012-13. And a wonderful drug called Palladia is coming into the picture. It was labeled for non-resectable mast cell tumors. And we started at that point, I think we were talking about KIT mutations and, all of those things that are more common language now. But back then, it wasn't really discussed, especially amongst the general practitioner community. I contacted an oncologist from the area, and she really was wonderful. And we said, should we do Palladia? Or there's another drug kind of that. And we're going back and forth. And she was like, I think you should do Palladia. So I said, done. So I ordered Palladia. And once again, we started it. This lymph node shrank, and she just kept trucking along. So,
this whole time, she's fine. It sounds like.
Fine.
Right.
I will say this, if anybody has ever used Palladia before, or maybe they're interested in using Palladia, one of the side effects that I saw when I started it that first week, she had incredible leg pain. So when she, and And I think that was just part of the mast cell tumor, being affected by this new drug. So much so for that first week, I was like, oh, is this something that I feel like I can continue? Consulted with oncologists that was so friendly and generous and helping me out along the way. And she was like, okay, we're going to take a vacation, a little break, and then start back, and she should be fine. And she never looked back. She did great. So we continued the protocol, and that girl lived another couple of years.
Oh,
so,
my goodness.
I know. She did great. About 6 months prior to her passing at the age of 16, she did have an arrhythmia that was so bad that she needed a pacemaker.
Oh, my goodness.
So we brought, I know, nobody in South Carolina did pacemakers. I contacted everybody in Charleston, Greenville, all the bigger cities. There's not a vet school in South Carolina. So I contacted University of Georgia and NC State. NC State said, can you come today? And I said, yep. So me and Sue and my husband, Chris, drove on up to NC State, and they put in a pacemaker, and once again, she didn't look back. So
that is crazy.
Yeah.
She was so strong.
She was so strong and scrappy. So I always say she's my heart dog just because she started my love for fighting cancer. And because she was so strong and she did so well with very, very few challenges, I felt like this is something I want to build upon. So that's how it all began. So, yeah.
What an amazing story. I know there's a lot of people listening who will be thinking a lot about what the possibilities are, especially those with mast cell tumors, but really any cancer diagnosis, you really don't know ahead of time. I mean, a 13-year-old dog, most people would do exactly what Sue's former dad's kids did and sort of say, well, she probably doesn't have that much time left, so why should we put a lot of effort into this? Let's let things take their course or make that choice that they made. All of these are valid choices, but if you're the person who's wondering if she's got something extra, if she's got that little extra bit, give her a chance if you can do it.
Absolutely.
Yeah.
No regrets. We had no regrets about any of it. Even with the pacemaker, we were at the point where it was, okay, she either has to be euthanized today because she can't live like this. Her heart is going to stop, or we have to take this risk with her. And, of course, it's expensive. My husband and I were looking at each other like,
right.
trying to like, are we doing this? Are we doing this? And we left, and we had, no regrets. So, and I know, it doesn't always turn out as a perfect story for everybody. So I don't want to, paint this like rosy picture, but it was the right decision for her. And I'm so thankful that she did so well, and how much she inspired me to continue and do more. So, yeah.
Well, thank you. So you started doing chemo with your heart dog, Sue.
Yes.
And then you continued.
Yeah. So then right after Sue, we had this 3-legged cat named Tucker. Tucker, because he was nip-tucked. He came from the pound with 3 legs.
Oh.
And so he didn't have cancer, but he had a disease called cholangiohepatitis, which is a liver and gallbladder problem where his immune system was attacking his liver and gallbladder.
Oh, that sounds very bad.
Yeah. I mean, it is. It's not good, but it can be managed. And his skin was turning yellow. His eyes were turning yellow, but he felt good. He wanted to eat. So anyway, we made the diagnosis through aspirates. So we collected cells from his liver, and that's what his diagnosis was. I consulted with an internal medicine specialist, and I consulted with an internal medicine specialist, and that specialist gave him 1 year to live. And we started chlorambucil, which is a chemotherapeutic drug. It's an oral drug, and we gave that as prescribed. And Tucker lived 5 years with minimal side effects.
Sure.
His blood work, other than his liver enzymes being terrible because he had this disease, they never had any consequences from the oral chemo. He never got immunosuppressed. So he too was a rock star that beat all odds. So that not only was Sue, but then Tucker, it just reinforced. So at that point, it was like, I don't want to say it was like a drug, but it kind of was. I just wanted to learn more and more and more. And so I was just investing a lot of time and continuing education and, any kind of certification that I could get, I was doing it. So,
In oncology.
In oncology, yes.
Uh-huh.
It was definitely my favorite area. So,
Did you ever consider getting board certified, becoming an oncologist?
yes and no. So kind of going back to my vet school career, I graduated at the young age of 26. It sounds so young now. But,
I'm with you. Yeah.
just the young age of 26. And at that time, if you think about, I had been in school for 21 years, if you count
Right.
kindergarten on them. And I was in debt with student loans, and I was ready to make a living for myself. I was ready to hustle, if you will, and just wanted to get out in the workforce. And so I didn't have any thoughts at the time that I wanted to do an internship or residency because it's 4 more years of I probably would have continued those loans. And they work so hard, and, the pay is, it's just a very, very modest income for those interns and residents because they're still getting their education. And that wasn't the right decision for me. So I went out into the workforce, but there's been times since then where, I just love oncology so much. And if I'm, hands deep in a full mouth extraction, removing cat teeth, I'm thinking to myself, wow, I sure do wish I was an oncologist right now. But that's okay. I mean, I like the variety of general practice. So no regrets. I love oncologists and, I love having them as a resource, but I think I'm right where I'm supposed to be.
Well, that brings me to something I wanted to talk to you about because I know a lot of, there are only, I'm going to get the exact number incorrect. So let's say there are over 400 oncologists. Not all of those are small animal oncologists in the United States. And so there's something like 60,000 general practitioner vets. So there's many, many more general practitioners than there are oncology specialists. And so especially in the last few years when the veterinary industry has been undergoing so much change and under so much pressure due to the pandemic and other kind of industry-wide there's all sorts of things going on, right? That affects the ability to give care. I know that at one point last year, at least, there was a 6-month average wait to see an oncologist, and 6 months to see a veterinary oncologist, and 6 months to wait to see your veterinary oncologist might not be enough time.
No, and some of these pets only have 6 weeks.
Right.
Our lymphoma dogs, it's unacceptable. And I feel so bad for the industry because, they truly are doing the best they can. But
of course,
there's way more animals that have cancer than oncologists can handle. So that's where I think it is important for general practitioners to be empowered to do as much as they can. I think it is just really hard if that's the only option. If an animal gets diagnosed with cancer, just say, well, there's a 6-month wait with an oncologist, or I'm comfortable dispensing prednisone. There has to be a middle ground where there's things that we can do in the intermediary in order to still fight cancer. And I think that we can do it well. So.
Right. And you have gotten that feedback from oncologists, correct? That do they resent? Is there a professional resentment that you're taking clients away from them as a general practitioner?
I don't think so. I'm sure that there may be a few, that may think to themselves, well, maybe y'all should stay in your lane, but I've not gotten that. I've gotten nothing but positive feedback. One of the things that I think it's very important that I communicate to my clients is that I tell them I am not a board certified oncologist. If you want an oncologist, we're going to make that happen. We're going to refer you, especially now I'm living in a bigger city than previous places. I do offer that, but I also say, on the other hand, I am very comfortable with doing chemotherapy. Here is my background. Here's my experience. Here's why I love to fight cancer. So this is an alternative if you do not want to go that route. So I feel like anytime I've talked to an oncologist, they've been very, very helpful, and they haven't been, discouraging or frustrated. And I definitely don't feel like they think we're stealing their business. I think they are probably, I would hope, appreciative if we can take those basic not boring, they're not boring to me, but, maybe the ones that are a little more straightforward, like a CHOP protocol or
for lymphoma.
Just carboplatin for osteosarcoma, or just things that are pretty routine or standard or simplistic, and just save those big guns, those hard cases, save the ones that really, make you scratch your head, or using drugs that have more side effects or more complications, or just maybe a different perspective. So I would like to hope that they are comfortable with general practitioners doing so, as long as they are doing it the right way. And that's what's so important. We have to be doing it to the level that they are doing it. Otherwise, we shouldn't be doing it at all. So,
right. So what are the things that you do in your practice to give chemotherapy to patients that a general practitioner listening or a dog lover listening would want to look for in their general practice to make sure that this is safe for everybody? Because it's not just the dog or the cat, it's you as a practitioner, right? Like, you want the humans to be safe in the practice.
Absolutely. I mean, you put the nail on the head. Safety is the most important thing, not only for dog safety. Chemotherapeutic drugs have such a narrow margin of safety that you have to get that math correct. For certain drugs like gabapentin, we use it for pain and anxiety and sedation in dogs and cats, or, an antibiotic, or even a pain medication like Galliprant or Cytopoint. These are all drugs where, we may give the same dose to an animal that's 10 pounds as we do an animal that's 19 pounds or 20 pounds. So there's this huge margin of safety there in a lot of these drugs where we have a range. Chemo has to be exact. You can't just round up or willy-nilly or just approximate 1 cc per 10 pounds, or, you can't do that. It has to be done correctly. So one of the ways that I like to be as safe as possible from that aspect is I like a double check system. I like for my technicians to be trained to also do the math. And then I like for both of us to calculate the math and say, this is the dose that we are going to use, and we have to match. And if we don't match, then we recalculate. And so by double check system, then I feel like that's one way that we can be as safe as possible.
Where do you get those numbers from? Where do you get the numbers to calculate?
Yeah. So as far as the published doses, there's a lot of resources available. My doses came from just my previous experience through LSU. They gave us an oncology drug guide handbook, and, a lot of those haven't changed. Drug handbooks, literature, there's just various resources.
So these are all things that a GP can look up and find those published doses. Okay.
Absolutely. The more experience with chemotherapy, you'll kind of see that, okay, this is the drug dose, and there may be a slight variation, but there's not going to be a huge change in the doses that are given. With that being said, so we both calculate. That's the way that we keep the dog safe. And then the way that we keep people safe is by using safety measures such as PPE. That's called personal protective equipment. And I like to think of that as just like this safety bubble, this like a shield of armor, if you will, or, just making sure that every entry point of the body, like the eyes and the mouth and the nose, are all protected by this equipment. A face mask and a respirator mask, and then a chemo gown and double gloves or chemo gloves. So just that shield of armor, that needs to be worn by every single person.
Because these compounds they're very potent and effective, but you, if you're healthy, don't want them on your skin. Certainly don't want to ingest them.
Yes.
Right. Yeah. Because it does go through.
Upon. It does go through. It's frowned upon. Don't bring your McDonald's into the chemo room. Don't set it on the counter. Don't just spray it willy-nilly. Bad things can happen because they are considered hazardous drugs. They're dangerous if you are exposed to them chronically in an unsafe way. There's a study, and I don't remember exactly the resource, but they measured healthcare workers who are chronically given chemo over long periods of time. Maybe they weren't wearing the safety equipment. I don't know. I don't know the specifics, but they were actually measuring chemo in their urine.
Oh,
and yeah. And so what we know is that they can cause problems with unborn babies. They can cause cancer. It's hard to believe that, chemotherapy can cause mutations and that can lead to cancer. And so it is so important that we are safe, because I don't want to have cancer later on and wonder, was it because I was unsafe? I was lackadaisical and I didn't care. Or I would even be more devastated if one of my teammates got cancer and I put them in harm's way because I was just like, oh, it's just a quick injection, or this is no big deal. We can't see this happening in your body, so it'll be fine. Well, I would feel terrible if they got cancer because of something that I didn't do to protect them. So it is of utmost importance that if a general practitioner is doing this, they have got to make sure that they are safe, and they have to make sure that their team is safe. And if they don't do, and they're not, by doing correct math and double checking, they've got to do those things. Otherwise, they shouldn't be doing them, in my humble opinion.
This show is brought to you by dogcancer.com, where over 40 veterinarians, veterinary oncologists, cancer researchers, and science writers pull together to bring you better information today so you have no regrets tomorrow. We do the research, we talk to the folks in the trenches, and sift through the hype and the anecdotes. That's dogcancer.com. Start your own research at dogcancer.com today so you have no regrets tomorrow. Is there special equipment that you need to administer chemo or can a general practice, once they get the personal protective equipment, can they just start doing it? Or is there anything that they'd need to do in their practice to start offering chemo?
Yeah, absolutely. You want the more, the better, the safer you can be. And so a biosafety cabinet is absolutely preferred, which I think in a way, it sounds like it's so unattainable. But at my last practice, we were actually in the process of doing a new construction. So we put in a biosafety cabinet. It was less than $10,000, which that's a lot of money for sure. But it's doable if you are going to not only make sure your staff is safe, that you're safe. It's so worth it, and it pays for itself. Mm-hmm. So it's a very, very doable thing. So I definitely recommend that be, an investment, especially if you're going to be doing a lot of chemo.
Tell me what that is.
It's called a hood. You hear it being a hood.
Okay.
And so you draw up chemo underneath the hood, and it sucks all of the bad stuff up and out the building. So
okay. So it's like a giant exhaust system, basically.
Exactly.
So it's not floating around in the air while you prepare the chemo for a treatment.
You're trying to prevent aerosols from forming. And so it just goes up and out. Out of sight. So it's a doable thing. It doesn't sound attainable because that's not something you don't go in every single vet practice and there's that hood. No, very, very few practices have one. Like I said, we installed it in my last practice. I just joined a new practice and we're doing a renovation, and that one is also going to have a hood. So we've already picked that one out. So it's definitely something, it's that extra safety thing that really should be done. And as guidelines get stricter, there's something called USP 800 guidelines, which are super, super strict. They want you to do that too. So vets in a hood, if at all possible. If you do not have a hood, there's these wonderful little, they're called closed system transfer devices, which are these little plastic parts that I always imagine that they take the place of needles. So getting rid of needles, they're these little plastic tips that go on the end of the syringe that sit on top of the bottle of chemo, and that also fit on the end of the IV catheter. And it's a system that keeps all of the drug within that system so it's not aerosolized. So it doesn't, because if you're drawing chemo out of a vial, you pull that with a needle, you pull that needle and syringe out, well, there's going to be a little drop. There's a drop there. And then if you're not wearing your shield of honor, you're not wearing your shield, then you could intake that. So these systems are in place, and there's several brands. I use one that's called a Facial, but there's several brands available. They're very inexpensive, so probably $20 per pet. It may be $3 for this part and $5 for this part, but for $20 or so, you can get rid of the needles, and this device makes it all just one streamlined transfer system that keeps the chemo from being exposed to the air.
Because you're drawing the chemo out of the vial it comes in into a little syringe that holds the dose that you need to administer to the animal. And so it just keeps that so that it's all safe as it travels from the vial to the dog and is administered at that point. The needle comes on later once you're closer to the dog. Or does it go directly into a port?
It goes directly into a port.
Okay. All right.
No needle needed.
No needle at all.
Needles out.
Okay. Well, I mean, this is so granular, but I feel like this is the kind of thing that, if people are really considering doing chemo in their own practice, they want to know, like, it's possible to really do this safely and to transfer it safely and not put yourself at risk and your clients and patients and team members at risk.
Absolutely. Yeah. And so I learned all about these products just on YouTube. There's so many videos on how to use them.
Isn't that incredible? You can literally learn how to do anything on YouTube now.
Absolutely. So I watched all the videos and then we bought a few, and I just practiced with saline, and then we just got comfortable with it. So never looked back.
Are there any other safety protocols that people need to keep in mind?
As far as for owners after the fact, just not being or handling their urine, their feces, their vomit for about 72 hours, trying to have them go to the potty in a different area, just anything. Now, the amount of chemo that's in their urine or in their feces, it's very, very small. But once again, if you had this chronic exposure, willy-nilly, if you will, and then you ended up with cancer years later, I never want anybody to think to themselves, well, it was because I was lackadaisical back in the day. So
right.
Don't touch it. Just don't do it. Avoid
Just don't
it.
do it.
Yeah.
What about when you're using an agent like Palladia or chlorambucil is also given at home? Sometimes, right? So what about those dogs that are on a metronomic protocol.
Yeah, I know. It's kind of one of those things that with, Sue being on Palladia, and I had other dogs. So we definitely tried. You try your best. What I can honestly tell you is that two of the dogs that were living with the same time as Sue, they're still with us 10 years later, so they didn't have any repercussions from it. So I think you just do your best. For the owners, wearing gloves when giving it, wash your hands afterwards. Anytime Sue would have a mess or what have you, we would clean it up with, gloves, and we just do the best we can. But, it's hard. You can't have them living in a bubble. So just avoid it. Yeah. It's kind of like us in the world. We're surrounded by things that could potentially cause cancer. But we just do the best we can and limit and try not to lose a ton of sleep over it. So,
right.
Yeah.
And those lower doses, aren't those lower doses generally than what you would get by injection or intravenous in a clinic?
Absolutely. So those metronomic doses are going to be much, much lower.
So hopefully that'll also help to minimize risk over time.
Absolutely.
Yeah. What are the types of cancers or protocols that you feel most comfortable offering to your clients, and which would you tend to refer out?
Absolutely. So I think it is going to be an individual preference, what their experiences are. And over the years, I've kind of collected a repertoire of what I call like the common ones that, like, for example, I will treat a dog with lymphoma with CHOP, or a kitty cat with lymphoma with CHOP. I will do that. Osteosarcoma and the use of carboplatin. Feel very comfortable using that drug. Then blasting for mast cell tumors. Obviously, that was my first one. So,
that's your heart drug.
That's my heart drug. That's my first one. Then blasting's the best. Really all of the ones that are what I consider the workhorse drugs. These are the ones that you see time and time again. Lomustine, that's an oral drug. Chlorambucil, that's an oral drug. All of those I feel very, very comfortable with. I think the ones that maybe I would shy away from, there's a drug called Mustrogen that can have some very, very scary, or it's scary to me. I just don't have experience with it, but something that a dog that may have CHOP and maybe has gone through a couple of rounds of CHOP, and then now we're no longer responding to those drugs, I may recommend a referral at that point. Or at least phone a friend and contact an oncologist and say, hey, anything else that I can provide, especially if that client doesn't, want to go to an oncologist for whatever reason. So definitely phone those friends as much as I can or need to.
Yeah. So talk a little bit about that. What's the difference from your point of view of seeing your GP versus going to see an oncology specialist for the dog lover listening?
Yeah. So I think that there's pros and cons of both for sure. Pro of going to an oncologist is that that's all they do all day, every day. They have years and years of training and research, and they could probably do all of those things in their sleep. They're used to those conversations, and they're used to managing side effects because it is an all day, every day thing. So there's expertise there that's valuable. I think a con would be cost. It's going to be more expensive for sure. They're specialists. They can charge more. And that's definitely allowed and understood. The other thing is proximity. They may not have an oncologist within. I know my first job, I was an hour from Houston. My second job, I was 3 hours away from Dallas. So this not a practical feat for somebody to drive 3 hours to do chemo on their pet once a week for 4 months. So I think that, that is a disadvantage, is maybe proximity, because you did say earlier, 400 oncologists. Is that in the United States, or is that in that's the United States or the world?
No, that's in the United States. That's
okay.
And I think it's North America. I think that includes Canada.
Oh my gosh. Yeah. Even Mexico or Canada?
I'll have to look. We'll make sure that we'll put a link to the specialist website where you can find an oncologist. And if you use the find all of them, you'll see how many are members of the of the ACVIM, which is the certifying body for oncology.
Can you imagine living in like Saskatchewan, as vast as Canada is, and having a dog with cancer and, it just not having an oncologist for forever?
Kristen, Dr. Lester, in the state of Hawaii, we did not have an oncologist until 2018 at all.
Oh my gosh.
So Honolulu, Hawaii is the 11th largest city in the United States of America, and it did not have a veterinary oncologist. There's over 1 million people who live in that city, and they did not have a veterinary oncologist. So we literally did not have any way to refer out because we have a rabies quarantine in the state. So you can't even fly your dog to the mainland to get treatment and then come back. You can fly, but you can't come back unless they go through a rabies quarantine.
Yeah.
And so it was absolutely out of the realm of possibility to have an oncologist other than a phone consult until 2018. And now if you wanted to get chemo from that oncologist, you would have to get on a plane and fly a half hour, 200 miles from our island of Maui. Yeah. And that is not feasible. I would not be able to do that if I had a dog with lymphoma, knock on wood. I would absolutely not be able to take that kind of time and that extra expense.
Right.
Hundreds of dollars a week just on the travel.
Right.
Or gas prices. Driving 3 hours is not just about the time. That's a lot of money.
Yeah.
Right?
It becomes a deal breaker for a lot of people, for most people. I mean, like I said, right now I live in a busy city, so we do have a couple of oncologists here, but for the majority of my career, I haven't lived in the same town as an oncologist. So if we weren't doing it, then who would?
So the pros and cons of oncology, what are the pros and cons of seeing your general practitioner? Are they all sort of reversed?
Yeah. So I think the pro for a general practitioner that does chemo well, that does it responsibly and safely, is that they're going to know your pet. They're going to have that more personal touch because they've been seeing your pet for quite a while, and they know maybe a little bit about what you like to do on the weekends, or they may know, what is the funny things that your dog does, or that he ate a foreign body last year and that was dramatic, or
they might have a sense of how strong your pet is.
Yeah, exactly. Or what your pet looks like or seems like when they are sick. I love that when I know a dog or a cat well enough to where I can walk in and say, oh, something's wrong. This is not how Fluffy behaves. This is not how my dog's Jeffrey. This is not how Jeffrey behaves. Jeffrey's sick. I love that because that is just another level. You know those people and they become like your family. What I can honestly say is that my clients that I manage their pets' cancer, they almost become friends/family. They become part of my world. I take pictures of them. We become Facebook friends. It just becomes a whole level of community there. So that is very, very valuable. I think that, location, most of our clients are within, 30-minute drive. And so it's not a hard thing to bring their pet once a week. It's a lot easier. And then finally, it is going to be less expensive. So just the nature of general practice is going to be less than specialty. So
that's all very reasonable and honorable. And it sounds like there's enough work to go around. So if general practitioners are listening and they're interested in learning more about offering if general practitioners are listening and they're interested in offering chemotherapy services to their own clients, where do they start? What do you suggest?
Yeah, so I think that from a safety standpoint, a good place to start is the AHA 2016 Oncology guidelines.
Okay.
They really go through very nicely how to wear the PPE, the personal protective equipment well, and the type of hood, and I think it talks about the hood there, maybe not, so correct me if I'm wrong, but it gives you a nice basic guideline for doing it safely and how to communicate. YouTube videos on the facial, learn how to use those protector connector injectors.
We'll try to find some to put in the show notes for people.
Absolutely. I would love that.
Yeah.
I think they're all on humans. I think all the videos I watched are humans, but I know that there are plenty of oncology videos that have been published in the veterinary community. If you look carefully, you can see that they are too using the closed transfer delivery system. But anyway, and then continuing education. There are so many opportunities. Like I said, I started out, there was a lovely weekend course all about oncology, all about chemo. So it was like 15 or 20 hours of just sitting there and learning all about oncology. It's a vet folio, 4-hour, not accreditation, but just like an extra badge of honor, this certification that you can get just by learning all about chemo. There's so many different resources on even Facebook. There's a veterinary oncology information group where you will have people that post cases and say, what should I do? And there are several board certified oncologists that will respond and give advice through that Facebook group.
Isn't that great? Is that closed to, I imagine that's only for DVMs. It's not for lay people.
I know that you do have to ask for permission, but I don't know if they would, because I think a lot of LVTs get on there. I'm sure that there's probably some
veterinary professionals.
Yeah. So hopefully, nobody's in there heckling or I think they are monitored pretty closely, but yeah, so there's so many resources. And then finally, utilize telemedicine. There's several companies that they make a living by supporting boarded specialists that will get online and give advice to general practitioners that need it. And so I've utilized them several times. If I've had a hard case, I've said, hey, they'll look over my biopsy samples. They'll look over all of my staging. They'll look over what I've done, and then they will give their advice. And I've even had them type up protocols for me and say, here's the protocol that I would use. They charge a small fee, and then that fee gets passed along to the client. I ask the client's permission. I say, hey, you don't want to go see an oncologist, but I can do telemedicine with an oncologist. Would you want to pursue this? And they, 9 times out of 100, they'll say, heck yeah, we'll do that. So,
and that's you consulting with the oncologist. So
exactly.
The dog lover doesn't actually get involved, and they don't have to coordinate that. They don't have to do anything. You take care of all of that and then pass the fee on. That's really good service.
It's a great service. It's a 30-minute conversation with an oncologist that gives you their take on it and even gives you a little bit of, love and support. They have been very, very supportive when I've done that and haven't given me any kind of judgment or scoffing or, unsupport. They're like, yeah, let's do it. Let's fight cancer. So
yes, the oncologists that I know all have that attitude. Let's do it. Let's fight cancer.
Let's do it. There's always something that can be done.
There's always something. Yeah.
Yeah.
Wonderful. Well, we'll put links to some of those services in the show notes, and we'll put as many links as possible so people can continue to explore. And I just want to thank you so much for joining us today and sharing all of your amazing stories and your experience, because I know that a lot of people wonder about this. Can't my GP do this? And so hopefully this will inspire some GPs to explore this a little bit, because I think there's a lot who want to be able to offer services that maybe right now they're not able to for whatever reason. So it's good to get more people on board.
Yeah. And if anybody needs a pet talk or, because I will have young associates that know that I'm passionate about it, and they'll contact me and say, hey, can I do this? And I'm like, yep, come on, let's do it. And so if anybody needs a little pet talk, then feel free to reach out.
Okay, great. Yeah, you can find Dr. Kristen Lester through her profile page on our website on dogcancer.com. Dr. Lester, thank you so much for joining us today.
Oh, you're welcome, Molly. It was a blast. And thank you for hosting me today. So hope you have a wonderful day.
I hope you come back. Yes.
Thank you. All right. Bye.
Bye. Hoping for a regular dose of hope along with the latest information on dog cancer? Subscribe to our email newsletter, Dog Cancer News, at dogcancernews.com. Each week, we send support, guidance, hope, and information via email to dog lovers just like you. We know what it's like to have a dog with cancer. So join us and subscribe to Dog Cancer News at dogcancernews.com.
Thank you for listening to Dog Cancer Answers. If you'd like to connect, please visit our website at dogcancer.com or call our listener line at 808-868-3200. And here's a friendly reminder that you probably already know. This podcast is provided for informational and educational purposes only. It's not meant to take the place of the advice you receive from your dog's veterinarian. Only veterinarians who examine your dog can give you veterinary advice or diagnose your dog's medical condition. Your reliance on the information you hear on this podcast is solely at your own risk. If your dog has a specific health problem, contact your veterinarian. Also, please keep in mind that veterinary information can change rapidly. Therefore, some information may be out of date. Dog Cancer Answers is a presentation of Maui Media in association with Dog Podcast Network.